So just to introduce Dr. El Shakarawi, who's going to give us a run through in terms of hepatitis B.
Thank you very much indeed, Lindsay. Thank you to the British Liver Trust for inviting me to talk today. And thank you everyone for joining. So I suppose I'm going to do a bit of an ABC of hepatitis B. Sorry, that sounds like a mouthful. And I'm going to just briefly touch on the virus and a little bit about how it's transmitted, a little bit about when you get acute hepatitis B, when you can get chronic hepatitis B, a little bit about the kind of treatments that we offer and the monitoring that's involved, so the sort of the clinic visits and what we do during clinic visits with hepatitis B, a bit about its effect on the body, and maybe if we've got a bit of time, touch very briefly at the end on sort of some of the exciting new developments in the field of hepatitis B. I've not got any slides, and I've intentionally done that because I want to just briefly touch on things and not make it about as technical as sometimes slides do make things. So hepatitis B, what is it? Well, it's a virus. That's the first thing to say. And there are two kinds of viruses. There's DNA viruses, there's RNA viruses. Hepatitis B is a DNA virus. And it's probably a very old virus. And it is very, very common around the world to have hepatitis B infection. So the World Health Organization, which has these kind of figures, estimates that there's about 300 million people living with hepatitis B around the world. Now that equates to about 1 in 20 people around the world having hepatitis B infection. So it is probably one of the most common infectious diseases out there. And now, how do people get hepatitis B? And this is where there's a lot of myths, and a lot of these myths have led to stigma around hepatitis B. But essentially, the vast, vast majority of people who acquire hepatitis B acquire it either at the time of childbirth, so mother has hepatitis B and passes it to her child when the child is born, or there is household transmission between young children and they get hepatitis B that way. Hepatitis B can also be spread through blood, so blood transfusions, especially in areas of the world where screening of blood isn't as good as it could be. And it is also passed from individual to individual through sexual intercourse. So those are really the main routes of transmission, but the vast majority of people infected around the world are infected when they are very young. Now, that's important because if you're infected very young, the chances of you clearing the virus by yourself and it not causing a long-standing or what we call a chronic infection, all chronic means is that you've had the infection for more than 6 months. So the chances of you clearing the virus and not developing a chronic infection if you are infected when you are young are very, very small. So if you take 10 children who are born to hepatitis B positive mothers with a high virus level, then 9 out of those 10 children go on to develop a chronic infection. And the same occurs if you get the infection anytime in the first 5 years of age. And we think the reason of that is that your immune system isn't developed enough to allow you to fight the virus. Now, the opposite is actually true. If you take, for example, someone in their 20s who gets the virus through either contaminated blood or sexual intercourse, then the chances of them clearing the virus is very high. So 9 out of every 10 adults who get the virus clear it by themselves, and it doesn't cause chronic infection. Okay, so that's the first thing to say. So the reason that hepatitis B is so common is that the vast majority of people around the world get it when they are born and continue having it for the rest of their life, because at that point in time, they have a high chance of it becoming a long-standing infection. Now, vaccinating children when they are very young in their first year of life can therefore really, really help in terms of if they were going to acquire it from people in their household. Treating mothers who have very high virus levels also reduces the risk of infection, and vaccinating children born to hepatitis B mothers from birth also significantly reduces the chance of getting the infection. And that's why it's very useful when you have a patient with hepatitis B to try and work out as a doctor where they got it from, but also we try and ensure that everyone in that household is vaccinated against hepatitis B because of this chance, and it is a very small risk, especially adult to adult, of transmission from that patient to the members of their household. So generally what we do when we diagnose someone with hepatitis B is we ask for their household members to be checked for the virus. If they've got the virus, there's no point in giving them the vaccine. If they haven't got the virus yet, then the recommendation is that we vaccinate people. Okay, so that's how you get hepatitis B, and that's why it's very common around the world, because a lot of it is transmission from mother to child. What's the effect of having the virus? So actually, if you take 100 people with the virus, 80 to 85 of those people throughout their life don't suffer any ill consequences in terms of their liver disease. And part of the problem with hepatitis B and what we know about hepatitis B is it's very focused on the liver and the hepatitis B virus causing infection and scarring in the liver. And indeed, that is probably the most complicated and the most important complication of having hepatitis B. The fact that with time, you go through cycles of inflammation, and by inflammation I mean swelling and redness. So I compare it to, if you scratch yourself, you get swelling and redness around where you scratch yourself. If you scratch yourself the same place every week, then eventually you get a scar tissue. And the same process happens in the liver over many, many years in patients with hepatitis B, and you can eventually get quite sort of severe scarring, and what we call severe scarring as liver doctors is liver cirrhosis. So everyone thinks about liver cirrhosis in terms of alcohol, but other things can cause liver cirrhosis. Anything that causes inflammation in the liver can cause liver cirrhosis, and hepatitis B is one of those causes. Now, the liver cirrhosis is associated with two things. You can then go on to develop liver failure, but you're at high risk of developing liver cancer. And those are the two most serious consequences in the liver of having hepatitis B. What we are starting to understand more and more is the other consequences of having hepatitis B, both physical and psychological. So physically, people who have hepatitis B often are a bit more tired if you ask them. Some people have joint pains. Some people get very vague abdominal pain. That's probably a little bit of liver inflammation that we don't recognize in their blood tests. And there is obviously the psychological consequences of living with an illness that may cause you serious harm, that is associated with a huge amount of stigma, that for some people prevent them having employment opportunities, etc., etc. And that is something that as a field, as doctors, some of us are better at recognizing than others. And that's why the experience of people with hepatitis B is very variable around the place, depending on how your doctor or nurse understands the virus and thinks about it outside it just being a liver disease. So what can we do with hepatitis B? Well, the good news is we've got very excellent treatments. So if you are in that 15 out of those 100 people who are going to go on to develop liver scarring, we try and identify that. And we identify that by looking at both the level of virus in your bloodstream, because there are certain levels above which we know that liver damage is more likely. We look at whether there's any evidence of liver inflammation on the blood tests, and we look at whether there's any evidence of liver scarring. Now, 10, 15 years ago, that would involve doing a biopsy once every 5 years. That is no longer that is very rare now, very rare that we biopsy people with hepatitis B. What we can do is use something called a FibroScan, which is a test that's about 5 minutes long, a bit like having a jelly scan, but we pop a probe in between the ribs over your liver, on the skin, doesn't hurt at all, and it gives the liver a little flick, and we measure what comes back, and that tells us how scarred the liver is. And if we've got a patient who's clearly either got a very high virus level, or evidence of liver inflammation, or evidence that the liver is becoming more and more scarred with time, we can put them on treatment. And the treatment is very good at bringing the level of virus often from like the millions down to like 0, or lower than what we can detect with the standard assays that we use, standard tests that we use. And that prevents liver damage moving forwards, and we know it reduces the risk of liver cirrhosis, that severe form of liver scarring I mentioned, and it reduces the risk of liver cancer if people are on treatment. But that treatment doesn't cure people of the virus, but it does prevent the complications. And most people we start on these treatments, we say to them, we will probably have you on this lifelong. That was what the conversation was certainly 10 years ago. Now, one thing that is possibly changing, and this is where I'm going to end, and I'm happy to answer any questions people have, because I think that's a better way of learning about the virus. But one thing that might be changing is that we are really starting to get interested in the idea of what we call a functional cure. But effectively, it's allowing the immune system to control the virus such that you don't need to be on treatment, and two, it prevents the damage from the virus occurring in the longer term. And it's still early days in this program, but there are clinical trials starting, and we are offering patients, small numbers of patients, the chance to participate in clinical trials in some of the bigger centers. And we hope, although it's by no means certain, that in 5 to 10 years' time, we might be able to offer people a cure for hepatitis B. But one thing I'd like to say is it's not going to be the same as hepatitis C, where you take a tablet for 8 to 12 weeks and it cures you of the virus. These treatments are likely to be a lot more complicated, potentially likely to include injections, potentially likely to be a year, but the goal at the end is to try and cure people with the hepatitis B virus. So really, I think that's all I wanted to say. And obviously, more than happy to take any questions that people may have. So Lindsay, back over to you.
Thank you so much. That was really, really interesting. I can see some questions already, so thank you. So don't worry, no one needs to shout out. There's no pressure to answer any questions, but we're just going to do a quick sort of true and false. So just kind of thinking out loud to yourself, and I'm going to test your knowledge. So true or false, hepatitis B can be caught through sharing cutlery. And yeah, I'm sure you all knew it is false. So hepatitis B, as already discussed, bloodborne virus, through infected blood. So you can't catch it through sharing cutlery, hugging, kissing. Next. So if I've had a past infection and cleared the hepatitis B infection, I still need to inform medical professionals. So that's true. So people who do not have a chronic hepatitis B infection anymore, so they previously had an exposure to hepatitis B and were able to clear that infection, they are no longer infectious, it's no longer bothering their liver. However, because it lies dormant in the DNA, it's really important to tell medical professionals about your previous exposure to hepatitis B, because some medications might reactivate the hepatitis B virus. So some steroids, chemotherapy drugs, some medications for hepatitis C treatment. So it's always important if you have been exposed to the Hep B virus, just to let people know. True or false, I will get cirrhosis of the liver if I have hepatitis B. And that's false. Again, as mentioned, so not everyone with hepatitis B shall get cirrhosis. One of the most important ways of preventing this is knowing that you have the hepatitis B virus and getting linked in with specialist care. As you know, that's a challenge. A lot of the symptoms, people are symptom free if they have hepatitis B, wouldn't think to get tested, don't want to get tested, have never been asked to get tested. And this is really important to me and reflective in the calls we have in the helpline here at the British Liver Trust. So true or false, I have chronic hepatitis B, but my liver bloods are within range, so I don't need reviewed by a liver specialist. Is that true or false? And it's false. So I would say a common phone call we get from people are they've attended their GP, they've told them that they are hepatitis B positive, and that that GP has said through whatever reason that your liver tests are fine, liver bloods are fine, you don't need referred to a specialist service. That's not true. So NICE guidelines state, so NICE guidelines are national guidelines. All right, so they state that all those who are who have chronic hepatitis B, so you have the hepatitis B virus chronically, should be reviewed by a specialist. Now, if a specialist says you're okay, then that's great, but that's for the specialist to tell you. So if you've been to your GP and they've said that you don't need seen ever, you don't ever need referred, I would suggest highlighting that to the GP and perhaps going back to them to ask for a referral to specialist care. possible questions to ask your doctor if you're seen by a specialist. A lot of these are available on the British Liver Trust website. But if you're wondering, if you have an appointment with a liver specialist to talk about your hepatitis B, I'd suggest making a list of questions, because people forget things. People forget their symptoms, their medications, past medical history. So my suggestion would be organized, write everything down, take someone with you if you're able to, and yeah, have a think about what's important to you, versus, and what's important to the clinician and what's important to you are different things. The clinician wants to get certain information, check for your liver staging, all these kind of things. You probably have some other different questions that you want to ask. So suggestions might be, what stage of liver disease do I have? Do I need medication, and what are my treatment options? Which tests shall I need? How frequently shall my monitoring be? How can my loved ones get tested and vaccinated? And are there clinical trials I can be part of? So, like I said, a couple of random slides, and a bit of a whistle stop tour. So I hope that made you have a little bit of a think. So thank you. So next, I'm going to introduce Amanda. She is a supporter here at the British Liver Trust, and really pleased that she is going to share her patient journey living with hepatitis B. Thanks, Amanda.
Oh, hi, everyone. I'd never heard of hepatitis B until I was diagnosed with it. And to start with, it was a really, really, really dark time for me. And what does worry me is that so many people are still stuck in this darkness. I'm 65 and an ex-teacher. I was diagnosed with Crohn's disease in the autumn of 2019 and had extensive blood tests so that doctors could decide which medication to put me on. 3 or 4 days before Christmas in 2019, I received a phone call out of the blue from a hepatology nurse who told me that the Crohn's blood tests had flagged up that I had hepatitis B. I thought it was something to do with dirty water, but every single search engine came up with drug addicts and unprotected sex. So I kept thinking, that's not me. It must be a mistake. Christmas was ruined, and I cried the whole time, asking, why me? I had my first hepatology appointment in the first week of January and was expecting to go in and be told that they got the diagnosis wrong, but of course they hadn't. The nurse I saw was lovely, and I feel lucky to be in the care of such a good team. I was told I would have a fibrous scan and an ultrasound scan, and thankfully the results came back normal. Doctors changed the medication they were going to put me on for my Crohn's because it could have had an adverse effect on my liver. And I was put on an antiviral medication to reduce the hepatitis B viral load. I thank God every day that I was diagnosed with Crohn's, because through that, I discovered my Hep B. I feel so lucky and privileged that the tablets are working, because the Hep B could have done a lot of damage to my liver. I shudder to think that I could have gone through life without knowing it. When I was first diagnosed, I was full of shame. I did tell some of my very close friends I thought I could trust. I was terrified of anyone else finding out and looking it up on the internet and thinking, oh, what's she been up to? I didn't go to the dentist for 2 years after I was diagnosed because I didn't want to fill in that medical form. It was bad enough putting Crohn's on it without Hep B as well. He'd been my dentist for donkey's years. What would he think? Having a Hep B is so lonely, and I had no idea how many other people have it. I wanted to reach out to other people like me, so I joined the British Liver Trust online Hep B support group. It was nice to talk to other people with it. We have a monthly meeting with Kenny, who runs the group, and he will tell us about anything new in the pipeline. And suddenly there are so many exciting developments on the way for a condition that has so often been overlooked nationally and worldwide. It's good to talk to other people in the same situation. You feel like you're not the only one in the world with Hep B and somebody else understands. I think the support group was instrumental in moving my life on and to tell my story. I've now accepted the diagnosis and I'm determined to shine a light on it. I now own it and refer to it as my Hep B. It was a gradual process. I thought, do I stay here in my cave for the rest of my life, or do I do something about it to help others? If anybody had told me within 2 years I would be telling my story, I would have never have believed them. But at 65, I just don't care what anybody thinks anymore. I'm also a Christian, and part of me thinks that God has put me in this situation to make a difference. Wanting to make a difference to others drives me more than anything. I've now started talking openly about my Hep B. Most people I tell say, oh, I'm terribly sorry, poor you. So I'm not getting the stigma I thought I would. I used to think that everyone I told would go home and Google it. But they're not, because they've got too many other things to worry about. And within a couple of minutes, they've forgotten about me anyway. Of course, there is stigma out there, and that needs to be challenged. If it is not challenged, it will persist. But my own personal experience is that most people are too busy with their own lives. I would say to anyone who does stigmatize me that no one has the right to judge other people. It can happen to anyone, and you're very lucky that it isn't you. The best way to challenge stigma is through education. So many myths out there. Hepatitis B can affect anyone, and more than anything, I want people to get tested. If I didn't know I had it and was symptom-free, how many more people are out there a walking time bomb? I will also tell people not to self-stigmatize and to talk about it. I've been so lucky to have a husband and children who have loved and supported me every step of the way and to cheer me on from the sidelines. I'm desperate to make a difference in any way I can. I can talk for England on hepatitis B. I'm just so passionate about it. Anything I can do to help people with Hep B, I'll grab with both hands, because I just want to be that light that shines on it. I believe we all need to share our stories, and the more I talk about it, the more I feel it needs to be talked about and normalised. Otherwise, how will the perception of it ever change?
Oh, Amanda, thank you so much for sharing. That was just so brilliant. And I'm sure so many people who are watching the webinar it will really resonate with them and hopefully provide them a lot of comfort. So thank you so much. Thank you.
Pleasure.
So now we're going to hear from Sarah Williams, who's publications and information here, a manager here at the British Liver Trust. She's going to provide us an update in terms of what the charity is doing in relation to hepatitis B. Thanks, Sarah.
Yeah, so I'm here to talk about the work that the British Liver Trust are going to be doing. As we've heard from Amanda just now, spoke so eloquently about how kind of hepatitis B affects people, not just kind of as a virus, not just as a condition, but in lots of other ways. And at the British Liver Trust, we know how important it is that we can kind of challenge and change that. So we've been working to develop a lot more work on hepatitis B that we're going to start to bring from April. And we're really excited about everything that we're doing. And we really recognise kind of what Amanda was saying, what Ahmed was saying as well, about how it's so important to kind of be listening to the experience of people who have hepatitis B and putting them at the heart of what we're doing. So in putting this plan together, we've worked with patients and we've worked with healthcare professionals to kind of come up with what we can do that would really make a difference, and that kind of the British Liver Trust, what is our role in helping to support people with hepatitis B. So our kind of main things that we're looking at are updating our patient information, making sure it's up to date, making sure it's really easy to use and understand, and looking at things like easy read versions, animations, and also the range of languages that we offer. We also want to raise awareness and bust myths. Thank you so much to Amanda for sharing her story. I think she's absolutely correct when she says that's one of the most important things that people can do to help tackle stigma and bust those myths. We're also going to be working with communities and people who are affected by HPV across the UK, both in sort of terms of understanding how we can best support people, but also to make sure that, yeah, we're doing the right things and we're doing the things that actually matter and make a difference. And lastly, as a charity, you know, we're in quite a privileged position to be able to kind of, you know, get the ear of some politicians sometimes, and those people who are deciding on health policy. So we're also sort of influencing for change and seeing how we can make things better at that bigger level, in terms of whether that's sort of what the government are doing, whether that's sort of helping patients to be involved in research, and also working with our healthcare professional networks to think about kind of how people are being treated, and sort of what the care pathways look like. So we're kind of using all of the levers that we can pull, we're pulling. We've actually got one really nice thing. This is kind of hot off the press, and I'm probably not supposed to be telling you. But this morning, our Director of Comms and Policy, Vanessa Hebditch, she was with some other charities handing in a letter to the government this morning, asking to extend a really important programme that's currently just running in England, testing people who come into an A&E department for hepatitis B, hepatitis C, and HIV. And actually this programme so far to date has found 800 people who either didn't know that they had hepatitis B or weren't under treatment for their hepatitis B. So it's really finding a lot of patients, and we know how important that is, you know, to find people so that they're aware and they can get treatment and have their kind of condition monitored. So we're really proud of that, and there'll be a press release going out tomorrow, so keep your eyes peeled. I think the other thing I just kind of wanted to say was, if you would like to get involved, we would love as many people as possibly can be to be involved with our work and to know what we're doing. If you feel that you want to share your story like Amanda, that would be fantastic. And we also have things like our hepatitis B support group, which you can join, as Amanda did, to kind of get support from other people who are in a similar situation. There are opportunities to help kind of develop our resources, develop our policy. If you'd like to kind of be involved, sort of telling us kind of how to make our booklets better and that kind of thing, we would love to hear from you. We're working on those at the moment, kind of that's my big project right now. So if you would like to be involved, please let us know. And also you can find out what we're up to through our newsletter and following us on social media. You'll see us kind of talking a lot more about hepatitis B, kind of ways to get involved and what we're up to, as well as sort of sharing information and other ways to get support. So yeah, please do get involved. The best ways to find out more or to get in touch are to visit our website. We have a page all about our hepatitis B work, or you can drop me an email. If you want to scribble that down now, feel free. We'll also be circulating an email around probably next week with all the key links to our information, and I'll include my email address in there. So if you do want to find out more, you are very much more than welcome to get in touch. That would be brilliant.
So thank you, thanks for the update. I hope that was interesting to you all. Okay, so I'm just going to look through the question and answer. So please, if anyone has any, please ask, make use of us here. So Dr. El-Sharawi, there's loads for you. so I'll just get started. So let's see what the time is. So why can someone only get hepatitis D if they have hepatitis B?
Okay, yeah, very good question. And it's a bit technical, the answer to this one. But essentially, hepatitis D, D for Delta, is what we call a replication deficient virus. Now, all that means is that the virus in its genetic material, in its RNA, because hepatitis Delta is an RNA, doesn't have all the necessary proteins to enable it to produce new viruses. So when if Delta by itself was to infect a liver cell, it would be unable to produce new viruses that could then infect other liver cells and cause damage. What it needs is some of the proteins that hepatitis B produces inside the liver cell to package the hepatitis D genetic material and enable it to cause damage. So that's the reason why you need both viruses in order to get hepatitis D related infection.
Thank you.
I hope that's clear.
So a couple about, okay, just so yeah, being in a relationship and talking about sexual intercourse as a means of transmission, and a little bit about vaccination, a couple of questions about vaccination for close contacts.
Yeah, so hepatitis B infection via sexual intercourse does happen, but it tends to be that the person who is positive, who then passes it on to a negative person, has a very, very high virus level. Okay, and I didn't go through the stages of hepatitis B, but initially you have very, very high virus levels in the millions, often in the billions. And then as you grow older, the body's your immune system matures, and often, not everyone, but a lot of people then get a partial control of the virus, and the level goes from levels in the millions down to levels in the hundreds. And if that's the case, then your infectivity, the chances of you infecting someone, if you've got that level of virus, is probably significantly lower. It's not zero, and it might be that the virus level fluctuates and you are more infectious sometimes than others, but that explains why actually there are a lot of couples who, despite not practicing barrier protection during sexual intercourse, still only one person is positive because the level of virus is low and therefore it isn't transmitted. There's another question further on, I might as well answer this because we're talking about sexual intercourse, about it being, can it happen? Hepatitis C classically is transmitted by men who have sex with men, but not necessarily in heterosexual relationships. Hepatitis B is different. It is passed through heterosexual sexual intercourse as well as homosexual sexual intercourse. It is partly driven by the fact that the hepatitis B virus is 10 times more infectious than the hepatitis C virus and 100 times more infectious than the HIV virus. So it is, of the three viruses that we talk about in terms of bloodborne viruses, the most infectious one. And that might partly explain why even heterosexual intercourse, but largely in people with very, very high viral levels, can result in transmission from one person to another.
Thank you. So again, a couple about so treatment for hepatitis B, again, sorry for yourself, Dr. El-Sharawi. One about treatment, when is it initiated? So only initiated when there's evidence of liver scarring, so it's not quite as straightforward as that. And then a question about PrEP as well.
Okay, so the question about why is treatment to suppress virus only initiated when there's evidence of liver scarring is a very, very good question. And it's one that will probably change. So currently, most doctors follow treatment guidelines from the big liver associations, the American Association for Study Liver Disease and the European Association for Study Liver Disease. And they recommend only treating the virus when you have liver scarring. Now, as I said, that's a very liver-centric point of view, and we are changing our thinking on that. It is a very valid argument to say, why wait until there's liver scarring? Why not just start too early? And in fact, the Chinese guidelines have just recently been published to suggest that everyone above the age of 30 with any level of virus should be treated. Now, that's partly because there's a huge number of people in China. It's partly because actually, initially when the drugs that I mentioned were introduced, they were quite expensive. Now the costs have gone down significantly, and there is no avoiding the fact that that has changed, and that early on, some of us think that part of the reason were these are very high cost drugs. That is no longer the case. And there are lots of moves, and there are moves to change the treatment guidelines. There is a new set of guidelines being written by the World Health Organization. There are patient advocacy groups internationally advocating for treating everyone who's got the virus akin to HIV. I think we're on that journey. I don't think we're there yet. But if I was giving this talk in 5 to 10 years, I might be saying to you, well, actually, if you've got any level of virus, you should have treatment to suppress the virus. Now, not every patient would want that, and that would have to be a discussion. And I certainly speak to patients where, for example, I can make an argument for treating them. There's no evidence of liver scarring, but I'm thinking they're going to need treatment in 1, 2, 3, 4 years. And I say, well, we can treat you now. And some people turn around to me and say, no, I don't want treatment now. Because for some people, that psychological hurdle of having a tablet every day is not an insignificant one. So I think it's a very good question. I think you have to treat the individual in front of you. And I think it's something that will change with time. So sorry, I went on and on. It was one of my passions, this question.
Can I ask a question then?
Okay.
So interferon seems to have kind of fallen out of favor anecdotally. That's kind of what I hear from medics. Would that be true in your sort of opinion?
Yeah, so again, this is quite complicated and technical. So interferon is an injection. Interferon is a chemical your body produces to fight viruses. If you've got a cold, you produce natural interferon. So interferon injections were initially given to treat hepatitis C, but also used to treat hepatitis B. And they're an injection once a week that are given often for a year. Now, horrible side effects from interferon. That achy feeling, that feeling of feeling lousy and not wanting to get out of bed. A lot of that is caused by interferon. So the fact is that it's not an easy treatment to give. In some very selected individuals, interferon is very useful, but you're right, it's generally fallen out of favor because these drugs are so good at suppressing the virus. There are some evidence and some data, especially from the Far East, suggest that combining interferon with some of the tablets in some people is very useful. But overall, I would say most of us as doctors want to move away from using interferon. But for the right individual, there's a good argument for using it.
Mm.
But it's a minority.
If you were co-infected with hepatitis D, would you treat with interferon?
Yes.
Yeah.
That's the current only licensed treatment for hepatitis D. There is another licensed treatment, but we don't have access to it in the UK yet. But that's a discussion for another day.
We'll get you back again. Let's see. So do I need to be checked for liver cancer if I have hepatitis B? Kind of goes back to, you need to be linked in with specialist services. So your liver specialist will be able to determine your sort of risk of liver cancer and what, if any, checks that you need. But that needs to be done through secondary care. Would that be fair? Yeah.
Absolutely fair. There are certain things. So if you're a male, your risk of liver cancer is significantly higher. If you're above the age of 40, your risk of liver cancer is significantly higher. If you've got liver cirrhosis, your risk of liver cancer is significantly higher. If you are of certain ethnicities, especially African, Black ethnicity, then your risk of liver cancer is significantly higher. So we make that judgment based on how you are, what stage of the disease you are, and patient choice as to whether or not to screen people for liver cancer. But again, it's something we're learning more about, and I think we're becoming we're applying liver cancer, what we call surveillance, so having an ultrasound and blood test once every 6 months more widely. That technology isn't infallible, so sometimes we miss things. So I think it's important to say that as well.
If I don't have any treatment, how often should I go for an appointment? Again, if you link in with your specialist service, there's quite often like a bloodborne virus nurse. If you get their contact details, they might be able to link you in, remind you if you're due any appointments, any scans. If you just ask your liver team, they will be able to hopefully let you know how often you should be going for your appointment, even if you're not on treatment. Defense, detoxifying, reverse inflammation. So in general terms, no, the liver detoxifies itself. So no, certainly wouldn't recommend taking anything as a preventative measure. And in fact, there's kind of no evidence really to suggest that, liver detoxes or anything, they don't work. All they do is they kind of make the liver work harder, because the liver just has to process it. Liver is a big factory, has to process everything, including, liver detoxes, herbal supplements. If I have a low viral load, can I still pass on to my baby during childbirth?
Yeah, so the risk is significantly lower. So the lower the level of virus, the lower the chances of you passing it to your child. Generally, we say at a threshold of 100,000, if your level of virus is above, then the recommendation is to take treatment to suppress the virus in the last trimester, in the last third of your pregnancy. And generally, we give it for another 3 to 6 months after as well. The risk of you passing it to your baby, I say, with low level viruses is significantly lower. But that's why every child who is born is vaccinated at birth. They get what we call a birth dose vaccine to reduce that risk significantly. It doesn't reduce it to zero, but it reduces the risk significantly. But the lower the level of virus, the less the chance of passing it is.
About post-transplant. So was born with Hep B, leading to liver transplant in early 60s. Currently on antivirals post-transplant, am I still considered a Hep B carrier?
Yeah, that's a good question. Again, technical. So the answer is no, theoretically, because when we replace the liver, if we are, so again, it depends, but essentially what happens when you have a liver transplant hepatitis B is that you take the old liver out, you give an antibody against the hepatitis B virus that hopefully enables the new liver not to be infected. And that antibody is often continued for the first 6 months post-transplant and then stopped. We measure a protein called surface antigen, which tells us whether there's any hepatitis B in the new liver. And the vast majority of people post-transplant are surface antigen negative. So we don't think the new liver is carrying the virus. But there is lots of variables in that, which is why I'm saying it's a bit technical. But no, you shouldn't. If you've had a new liver, you shouldn't be called a carrier, by and large, in the majority of cases.
Okay. And yeah, a question about carrier status. What does that mean? So a couple of things. It can mean, again, it very much depends on how a person describes. So I hear it in two variations. So I hear it, I'm a carrier. I quite often get people on the helpline who've had a previous exposure to hepatitis B and cleared the virus. They have been told they have carrier status. So I hear that from patients on the helpline, certainly. In terms of chronic hepatitis B, in this sort of again, tell me if I'm wrong, but when you're in this sort of low level amount of virus, the liver is kind of not doing much, just kicking around. Quite often that has been called carrier status. Would that be
Yeah,
right?
and that's an old terminology. So we're moving away from that because I think it's really confusing for patients, and I think it's not helpful. So we now talk about chronic infection and chronic hepatitis. So if you've got just infection with a low level of virus, I say just infection. If you've got infection with a low level of virus, normal liver blood tests, no evidence of any scarring, you've still got the chronic infection. And that, some people used to call that carrier status. If you've got inflammation being caused, that redness and swelling I mentioned, like for example, when you scratch your skin, your liver tests are abnormal, then we call that chronic hepatitis. And those are the people that we treat. So carrier, I never use it anymore. I never use that because I don't think it's helpful. The reason is if you've cleared the virus yourself, or if you've had one of these new functional cure agents, although the virus is no longer active in your liver, there is still residual, what I mean residual, there is still part of the genetic code of the virus left in your liver cells. And that's important because if you then have treatment in the future, like anti-rheumatoid treatment or something that really suppresses your immune system, some forms of anti-cancer treatments, and it can cause the virus to return, start dividing again in your liver and cause quite bad hepatitis, and people have been known to die from that. So I suppose that's the important message. I don't like the word carrier. It doesn't really make any, it's just quite a stigmatizing word, I think, personally. So yeah, so that's what I would say.
Thank you, Dr. El-Shagharmi, for answering the majority of these. Very briefly, should I tell my employer if I have hepatitis B? That's entirely up to you. Certainly a discussion that you could have with your occupational health if you want. There are some professions when you're so it's exposure prone procedure, so dentists, doctors, am I right, you have to
healthcare workers generally have to well, you're generally checked, to be honest, but you have to disclose. So anything where there might be a blood-borne transmission, but no, if you are in a non-healthcare associated job, you are under no legal obligation to disclose your hepatitis B status. There's another interesting question: is someone on tenofovir for viral load management, can they switch to PrEP to protect against HIV infection? So I My understanding, well, I don't know enough about PrEP. The thing about hepatitis B treatment is that you need to be taking it regularly. Yes, some of the PrEP agents have this treatment called have tenofovir in them. So actually, theoretically, if you're on the PrEP all the time, then you can switch to PrEP to prevent HIV infection. But my understanding of PrEP is it's given intermittently, and that will be bad for the hepatitis B, because when you're not on it, the hepatitis B will come back. So again, I think that's a discussion you have with the people providing you with the PrEP. But again, as I say, I'm not 100% sure how the PrEP is given. So that will be my answer to that question.
Thank you. Thank you very much. So Amanda, I have a quick question for you. Thank you very much for answering all of those. Thank you, Dr. El-Sharawi. Amanda, just very quickly to say that someone has said that thank you very much for sharing your story. You're an inspiration. So I just wanted to share that with you. And as a sort of, as a final question to round off tonight's webinar, if someone is faced with a diagnosis of hepatitis B, what would your top three kind of things? What would your first three things would be to reassure them?
Okay, I think thinking about it, I've thought about this for a long time. What would I tell somebody? So I've got four things.
Great.
First of all, don't self-stigmatize or blame yourself because it's not your fault. I mean, for a long, long time, I was beating myself up that it was my fault, and don't do that because it's not. Reach out to others. Don't stay isolated, because I think that is where you stay in the darkness. If you're isolated, just reach out. Get information from a trusted source on the internet. There's so much misinformation. I think go to the British Liver Trust website and the National Health website, or some of the bigger American, the Hepatitis B Foundation. Something that's trusted. Don't just keep Googling it and some really, really bad stuff there that you just shouldn't believe. And last of all, I think don't be frightened. I think you're braver than you think.
Thank you. Thank you. Well, that's a lovely note to end on. So I'd just like to thank everyone who has contributed to the webinar this evening. Dr. El-Sharawi, Amanda, Sarah, thanks for everyone who helped with this webinar this evening. And thank you everyone for coming along this evening. This is going to be up on the YouTube, British Liver Trust YouTube channel in like a couple of weeks. So feel free to have another look at it. Briefly, just to highlight the sort of support that we have. So we've got the nurse-led helpline, and we also have an email service, virtual support groups, and please have a look at the website, and hopefully there'll be information there that you find helpful. So thanks very much everyone for coming along this evening, and have a great rest of the evening. Cheers now. Bye bye.